kasih.
Okay, Assalamualaikum. Selamat petang. Dr. Fatihah pada Kkti intern lah. So today saya present mengenai CPG on management of rhinosinusitis in adolescent and adult juga. So a bit of introduction. Rhinosinusitis, kita panggil RS, poses a major health problem and affect the patient quality of life, and majority patient present in primary care setting lah. So it is characterized by a mucosal inflammation of the nose and paranasal sinus, and diagnosis of rhinosinusitis including history and endoscopic sign, ataupun by using CT scan past history of rhinosinusitis. So the diagnosis history, kita kena ambil 2 or more of the symptoms. Ada nasal obstruction, blockage or congestion, nasal discharge, patient presented dengan runny nose, post-nasal drip, facial pain or any of facial pressure, reduction or loss of smell. So the diagnosis, satunya kita do an endoscopic sign. We look at any of nasal polyps, mucopurulent discharge, mucosal edema. From the CT scan, kita nampak mucosal thickening, any of past history of chronic rhinosinusitis lah. So dekat sini example of nasal polyps, and then sebelah dia is a mucosal edema and also mucopurulent discharge. So kalau from primary setting dekat KK, kita boleh buat anti-rhinoscopy. So kita boleh nampak any of mucosal edema, any of polyps or nasal discharge. And for the chronic rhinosinusitis, usually the best tool is for kita buat nasal endoscopy lah, which is usually under ENT. So ini kita buat under primary setting for anti-rhinoscopy for acute rhinosinusitis lah. For nasal endoscopic examination, usually under ENT department for patient ada chronic rhinosinusitis. So the classification ada 2 types, which is acute atau chronic. So the based on the duration of the symptoms. For the acute, any of worsening of the symptoms after 5 days, and then the symptom persists after 10 days but less than 12 weeks. However, in chronic rhinosinusitis, the symptom persisted for more than 12 weeks. In common cold, kalau symptom dia less than 5 days lah. So dekat sini we nampak graph dia. Kalau acute rhinosinusitis akan start after 5 days, and then dia akan persistent after more than 10 days but then less than 12 weeks. Kalau persistent more than 12 weeks is a chronic lah. So ni a bit about acute bacterial rhinosinusitis, or kita panggil ABRS. So must be at least 3 of the symptoms, which is unilateral purulent greenish or brownish nasal discharge, any of unilateral facial pain, fever more than 38, any increase of ESR or CRP, and double sickening. Double sickening ni maksud dia after the initial recovery, patient akan ada symptom balik and it's become worse, lagi worse compared to the first time dia kena lah. Okay, for the ABRS, the main pathogen usually is by Streptococcus pneumonia, Haemophilus influenza, and in children usually Moraxella taralis, and for anaerobic organism usually predominant in dental origin lah. So a bit about epidemiology. For the acute rhinosinusitis, the prevalence range about 6 to 15%, and majority for acute rhinosinusitis is viral in origin, and usually about 0.5 to 2% only complicated by bacterial infection. For the chronic, the prevalence rate is about 2.7 to 8% in Asia lah. So the main risk factor for acute rhinosinusitis is ada 2 ni, is acute smoker and active smoker and also allergic rhinitis. Other than that, patient is a second-hand smoker, positive family history of rhinosinusitis, any of underlying asthma, allergic or non-allergic rhinitis, contohnya macam chronic bronchitis ataupun underlying emphysema, GERD, sleep apnea, and also adenotonsillitis. Okay, So the severity of rhinosinusitis is depend on the VAS score, the visual analog score, 0 to 10. So pada sini kita boleh tanya patient whether dia punya symptom affect the quality of life or not. From 0 to 3 mild, moderate, 3 to 7. Kalau more than 7 is severe lah. For the chronic rhinosinusitis, the bacteriology is different from ABRS and the main pathogen is Staph aureus, enterobacteria bacteria dengan Pseudomonas. Okay, for CNS, culture and sensitivity, usually dia low predictive value in diagnosing ABRS and CRS. And usually kalau under ENT, dia akan buat endoscopic directum medial meatus culture which is under ENT department. Kalau patient who does not respond to the first and second line antibiotics. Imaging also, plain X-ray does not have no rules in diagnosis rhinosinusitis. The gold standard is by using CT scan. And indication for the CT scan, usually patient who is having failed medical therapy, plan for the surgery, rhinosinusitis with complication. So differential diagnosis lah between the allergic rhinitis, rhinosinusitis and also fungal. For the allergic, usually the nasal discharge will be clear. Rhinosinusitis akan muka purulent. Fungal presented dengan mucin nasal discharge. And then usually facial pain presented dengan rhinosinusitis. And then nasal obstruction, tiga-tiga will be ada. And fever usually present dengan acute rhinosinusitis. So the treatment terbagi pada dua, medical dengan surgical. For the medical therapy, first by using a normal saline nasal irrigation, function is to remove the mucus and act as an effective agent and inflammatory mediators, decreasing the nasal crusting and also increasing the mucociliary clearance. And then you can give an oral antihistamine for patient having underlying allergic rhinitis. Corticosteroid, either topical and also oral lah. For the corticosteroid, function is to reduce the inflammation and mucosal edema. The topical for acute, kita bagi for intranasal corticosteroid spray for about 2 to 3 weeks. For the chronic, 4 to 12 months. So under kalau dekat KK kita ada budesonide nasal spray lah. So for adult dengan children 6 years and older, for rhinitis, two spray into each nostril once daily in the morning. And then for the nasal polyp, 2 spray twice daily lah BD. And usually this one for patient have treatment and prevention of nasal polyps. Ada fluticasone which is ini under ENT. Oral corticosteroid, ARS kita tak bagi for acute, should not be prescribed because ada exacerbation of bacterial infection. For the chronic, usually prescribed by ENT surgeon, where kita bagi short term oral corticosteroid about 25 mg per day for 2 weeks. Antibiotic for acute, usually kita akan start dengan amoxicillin 500 mg TDF for 5 days. Other than that, start dengan Augmentin 6 to 5 mg TDS for 5 to 7 days. For chronic, antibiotic should not be used lah. Other medication in medical is decongestion. Topical decongestion should not be prescribed for more than 2 weeks because ada rebound phenomenon. And oral decongestion should be prescribed cautiously in patient having DM, CVS, glaucoma or BPH. Okay, other than that, analgesic, contoh PCM, NSAID to provide symptomatic relief. Other than that, mucolytic agent, antiviral kita tak bagilah for treatment of rhinosinusitis. Okay, this is the management of acute rhinosinusitis for primary care. Okay, so ini yang ada dekat dalam antibiotic guideline kan. For the rhinosinusitis, patient presented dengan 2 symptoms, duration more than 12 weeks. Contoh presented dengan nasal obstruction, frontal pain, spine disturbance, and then kita buat the anti-rhinoscopy, nampak ada polyps or any of discharge. So kita tanya patient the VAS score lah, mild, moderate atau severe. Okay, symptom less than 5 days is considered as common cold. Kalau more than 5 days, up to 10 days, saya boleh tanya dia punya VAS score. So for the mild ARS, VAS score 0 to 3, kita bagi symptomatic relief lah. And then symptomatic medication. And then kalau not improvement after 10 days, worsening after 5 days, can start topical steroid. And then kalau tak ada improvement after 2 weeks, consider to refer ENT. For the patient ada moderate atau severe, moderate the VAS score 3 to 7. Kalau ini kita boleh start the symptomatic medication plus dengan topical steroid. And then kalau severe, campur consider antibiotics lah. So the antibiotic ni kita boleh tengok any of at least 3 of the symptom. Severe local pain, fever, yang tadi tu lah elevated ESR atau CRP, double sickening, atau prolonged greenish nasal discharge. And then review back after 3 days. If dia ada improvement, continue treatment to 2 weeks. Kalau tak ada improvement, refer to ENT specialist. For the chronic rhinosinusitis, patient presented dengan 2 symptoms, duration more than 12 weeks. So sama juga symptom dia, and then kita start with the topical steroid, and then plus with the nasal irrigation, evaluate balik after 4 weeks, and then kalau ada improvement just continue therapy. Kalau tak ada improvement, refer to the ENT specialist lah. So this one for chronic. For the referral, either kita boleh refer either as early atau urgent. Kalau early within 1 week, urgent within 24 hour. So apa indication dia? For the acute rhinosinusitis, early referral kalau patient presented dengan persistent symptoms, despite the optimal therapy, especially in immunocompromised patient ada frequent recurrent more than 4 times per year. So kita boleh refer this patient, suspected malignancy, anatomical defect causing obstruction. For urgent within 24 hours, kita kena refer kalau patient presented dengan orbital involvement. Contoh periorbital edema, erythema, displaced globe, double vision, restricted eye movement or reduced vision, severe frontal headache, swelling, any of neurological manifestation or septic lah. So ni contoh kita panggil port puffy tumor kalau ada forehead swelling. So this one is an urgent referral to ENT, and also any periorbital edema. For the chronic rhinosinusitis, early referral kalau patient presented fail a course of optimal medical therapy, more than 3 times nasal infection per year, any of suspected fungal infection, granulomatous disease or malignancy. For urgent, within 24 hours, patient presented severe pain or swelling of the sinus area, particularly in immunocompromised patient. Contohnya for uncontrolled diabetes or ESRF or HIV lah. Okay, ni my last slide I think. For indication of surgery for acute rhinosinusitis, kalau tak ada clinical improvement after 24 to 48 hours of IV antibiotics, so kena consider surgery, and any orbital or intracranial complication. For the chronic, kalau patient have failed optimal medical therapy. Okay, itu saja Dr.
Okay, terima kasih Dr. Fatihah. Kejap jangan unshare dulu bagi.
Oh, okay.
Kita komen boleh sebab saya ngisahkan hadiran ni lah. Okay. Dr. Nandini sila. Saya dah minta dia prepare lah. Untuk komen.
Actually, everything already presented lah. I just want to mention about menthol. Last time we used to have menthol preparation for inhalation in Kktis, but I'm not sure now if they have. Actually, in acute rhinosinusitis, we don't recommend this menthol inhalation lah, as it can injure the mucosal lining. So try not to give and don't encourage patient to do any form of inhalation.
Hmm.
Ada ni, macam mana ramai tak patient dekat ENT yang kena refer daripada KK?
Acute jarang doktor, biasanya is chronic yang ramai. But they do get acute exacerbation with underlying chronic rhinosinusitis. But refer dari KK jarang lah for ni.
Selalu dia orang bagi yang sama yang kita bagi ke? Kurang juga macam mana?
They have the same thing, the budesonide nasal spray as well. And then but they do start steroid lah. Either oral, usually oral for a short course.
Ya,
And
dia orang
antibiotic when indicated.
saya nampak macam dia orang selalu bagi je, terutama kalau ada chronic rhinosinusitis dengan polyps kan, dia selalu je bagi
Yeah,
antibiotik.
steroid. Antibiotic when like the thing becomes more purulent, got pain or fever,
Kan?
then they do give antibiotic lah.
Dia orang guna apa selalu kat sana?
Augmentin.
Augmentin jugalah. Okey lah. Jadi boleh lah kalau unmanageable, kalau exacerbation sikit-sikit, kita boleh bagi rawat antibiotik, kita ada augmentin lah. Seperti dalam guideline juga, dalam AMS pun, clinical pathway pun boleh kita bagi augmentin lah. Ya. Okay, terima kasih Dr. Fatihah, terima kasih Dr. Najini. Ya. Saya ada masalah link ni sebab apa? Saya punya patutnya Google Meet boleh sampai 500 sijil. Saya tengok dia tak bagi pula kali ni. Dia bagi sampai 60 je sijil. Saya ada link lagi satu untuk berceramah. Kalau tak dapat juga email saya Dr. Suryata@emotion